Hi, everyone. Welcome back to the Neurology Nook. I'm your host, Kelly, with co host Dr. Sumul Modi here. We talk about common neurological conditions, focusing on education and spreading awareness. Thanks for joining us. Today, we have guest Dr. Aarushi Suneja. Dr. Suneja is a highly accomplished neurologist specializing in headache medicine. She currently serves as the Fellowship Program Director and Quality Improvement Officer at the Cleveland Clinic Headache Center. Dr. Suneja's impressive educational background includes medical school at Northeast Ohio Medical University, neurology residency at Henry Ford Health System, and headache fellowship at the Cleveland Clinic. Her commitment to compassionate patient care and academic excellence make her a leading voice in her field. So, Dr. Suneja, thank you so much for coming on our podcast today to share your knowledge about headaches. So, this topic is especially relevant to our practice, as you know, as we treat a lot of post-traumatic headaches or headaches after concussions and brain injuries. To start, sort of high level for our audience, would you tell us about the difference between migraines and headaches?
Thanks, Kelly, for having me. I'm excited to be here. As you can
Of
appreciate, I'm a
course.
headache specialist, so I have wonderful job security. 20 to 25% of the
Yeah.
general population has headache. But you can appreciate our job is to understand exactly what type of headache a patient may have so we can give them the appropriate therapy and get them feeling better, as quickly and efficiently as possible. So we have a Bible that we follow. It's called the International Classification of Headache Disorders. And even in your patients, other neurologists, you can read it yourselves. It's open access. It's called ICHD3 beta criteria. Everybody reads the same textbook all around the world in order for us to get the migraine diagnosis quickly. A pure definition of a migraine is a headache which is on one side. We call that unilateral, and it lasts between 4 and 72 hours. There is some sensitivity to light, loud noises, nausea, vomiting, and it has to interfere with your ability to do what you got to do. And it's moderate to severe in quality. You can appreciate that criteria is very cumbersome. It can be really
Yeah.
hard to remember. So whenever I have trainees with me, I tell them, forget all the mumbo jumbo. We remember 3 questions. That's called PIN. P stands for phonophobia, the sensitivity to light and loud noises. I stands for incapacity, or the inability to do what you got to do. And N stands for nausea. And if your headaches have 2 of those 3 conditions, it's likely to be migraine, and you should head down the treatment path of migraine.
Okay, great. PIN. That's
Easy to
great and
remember.
usable.
Yeah.
Yes. Thank you for that. So, can you tell us a little bit of the differences of what's happening in the brain in a migraine that's causing the migraine versus headaches? And we can get into that a little bit more later too,
Yeah,
to
headache is
compare.
generally just a word we use as a symptom, right? Most of us, it's hard for us to tell ourselves whether it's a migraine or just a headache. A headache really
Sure.
can be classified in lots of other things like tension type headache, cervicogenic headache, and that helps us understand where the pain is coming from so we can treat it appropriately. The migraine and headache world is a very hot place to be. It's a wonderful time to be a headache doctor, especially since 2018, because our understanding of migraine has really evolved and changed even since I was a medical student. So initially, we thought that migraine or headaches are related to the blood vessels vasoconstricting and vasodilating, just like a hose becoming tighter and looser. But more recently, we have an understanding that that's only part of the big story. We have an understanding of a new molecule, which is called CGRP, or calcitonin gene-related peptide. It's a peptide or a protein which is released in the trigeminal vascular system. That's in the neck, that's in the sphenopalatine ganglion, in your nose, in the trigeminal nucleus in the brain. And downstream, it causes all those symptoms that really bother patients, the throbbing pain, the sensitivity to light, loud noises, nausea, and vomiting. That's with spreading depolarization or electrical activity within the brain itself. So I tell patients often, we say all of these things, and unfortunately, migraine is a bad storm. It's related to genetics, hormones, and unfortunately, bad luck. It runs in families. So it's a very treatable condition. We can manage the condition, but unfortunately, there is no cure. But as we learn more and more, some of the newer agents on the market help us understand exactly where the migraine is coming from so we can, again, treat it appropriately with the right agents, which are designed specifically for migraine.
We have been seeing a lot of TV commercial of these anti-CGRP medications.
Yeah, I think Serena Williams and Lady Gaga and one of the Kardashians, they all have migraine. So you can appreciate how prevalent
Wow.
it is. they're all the spokespeople for some of these new drugs. And I urge patients, if you see a commercial with a drug on it, you should be talking to your neurologist about switching from some of the conventional therapies. It's important for patients to advocate themselves. If a medicine isn't suiting you, then bring it up to your providers, because we have so much more options than we have ever had before. And really, it's high time that our patients feel better. Their medicines are bothering them the least. They can go back to work, back to school, back to living their lives. It's a wonderful time for headache management.
That's great. Now, besides pharmacologic therapy, is there anything that patients can do in terms of lifestyle to try to prevent their migraines?
That's a great question. Usually when we see a patient for the first time, I tell them the medications will do their job, but you have to do your job. And that
Oh,
includes
yeah.
changing up the lifestyle, because medicines only work when we give them the right setting to work in. And
Yes.
usually that includes some natural supplements. We talk about supplements like magnesium, CoQ10, riboflavin having the highest evidence. There's also other devices on the market that are called neuromodulation devices. There are currently 5 FDA cleared devices on the market. These I like for my patients who are planning to conceive, for example, or patients that are pregnant, patients that are older. They don't want to be on lots of medications. They're as good. The data is so robust, as good as taking prescribed medications. But of course, all the good things that our primary care doctors are also preaching: 3 meals per day, 2 to 3 liters of water a day, minimizing caffeine to not more than 200 milligrams, getting good exercise, aerobic and weight training, 30 minutes, 4 or 5 days a week, so we get good blood flow to the brain, all the important things that we know. Have a good lifestyle and having a good routine. I always say that migraines are allergic to good routines. So if we can maintain a good routine and you do your job, and the medicines will do their job.
Oh, that's a great way of putting it. We were just talking before this podcast about how so much of neurology can seem really complicated, and it is. But oftentimes, when we're treating neurologic conditions, getting back to basics actually gets us at least half the way there. So, exactly like what you were talking about: exercising, sleeping well, eating well, getting outside, maintaining your social relationships, all of that goes a long way in treating everything. It sounds like migraines too. So, that's wonderful to add to the list there.
Yeah, I mean, migraine is a chronic condition. I have
Mhm.
migraine myself. I'm lucky it's very infrequent, and I tell patients all the time. Yeah, I
Oh, you
think
do?
many of us have migraines. So I always tell them it's a chronic condition. It's going to ebb and
Mhm.
flow throughout your life. So it's really important that you do your part, avoid your triggers. But unfortunately, sometimes, we cannot avoid those things. And that's where medications really play a wonderful role in our toolbox.
Since you talked about triggers, can you tell a little bit more about that?
Triggers is also a little controversial topic in the headache
Yeah.
world, because as we learn more and more, many of the things that we blamed, previously we used to think that when patients have dark chocolate or milk chocolate or red wine or MSG, or if they're dehydrated or they have too much to drink or they're sleep deprived, all these things that they had control over, that would induce a migraine. And in many patients, it's possible that this is a trigger. And we used to tell patients, okay, so just avoid your trigger. What's the problem? But I think we are encouraging patients that, of course, this may be a trigger, but it also may be part of the prodrome stage of migraine, a
Mhm.
precursor that a migraine is coming. That's why maybe you're craving the MSG or you're craving the chocolate.
Exactly.
So I think it's high time we probably destigmatize migraine for our patients. And much of this is out of their control. Identifying triggers can be really helpful, and if you can avoid it, wonderful. But if you can't, that's okay too.
That makes sense. And it sounds like there's a lot of room for more research on it's still just exactly what is happening in the brain when this happens too, and how to target that better. It seems a little elusive, a little mysterious still.
Mhm.
Yeah.
Yeah, it's probably mysterious. And the good thing is there are so many new tools in our toolbox. So I tell patients all the medicines are pretty good. They're kind of like gummy bears. You might like red, and my next patient might like orange, but they all taste very good. And so it's just about figuring out what's your preference. And that's why having a good therapeutic patient physician relationship can be really important. Having close follow up with your provider teams.
Yeah.
It's really a multidisciplinary approach. The physician and the
Yeah.
patient leading the team. But of course, our APPs, just like you, they see a lot of our
Mhm.
follow-up visits. We have psychotherapy on staff, physical therapy. As you can appreciate, it's not a one-man show by any means.
Yeah.
Absolutely. That's
Right.
great to provide really well-rounded care there.
Yeah. Since you mentioned
Mhm.
migraine is an elusive disease, one of the interesting thing that I find is the theory of cortical spreading depression and how
Mhm.
it's linked to migraine aura. I think our listeners would like to know about that.
Yeah, I think aura is a cool topic because as we know, I always remember that before the headache even begins, the headache, the pain itself, we know that there are other weird things that happen, increase in urination, yawning,
Mm.
increase in thirst, some brain fog, word finding difficulties, confusion, neck stiffness, even feeling sensitivity to loud noises and light. And that's called prodrome or the warning signs that a migraine is coming. Between
And
five
what
minutes and
happens in the
60.
brain
Yeah,
during that stage? What exactly causes it? Is it
right.
similar to a seizure or a stroke or some
Mhm.
other different phenomena in the brain?
Yeah, luckily it's not similar to a seizure or stroke, so we can feel
Yeah.
Yeah.
relieved about that. But generally, we think that some of the neuroinflammatory peptides, as I mentioned previously, probably CGRP, is being released at that time, and our body is getting sensitized, and a migraine is coming. And you talked a little bit about aura, which happens between 5 minutes and 60 minutes before the headache ever begins. And I tell patients that's your warning sign. And now more than ever, we should be treating early. Take your rescue medications at that time to help break your headache early so the headache is less bothersome. And usually that's happening because the back of the brain is being activated. That's what Sumul was saying, that cortical spreading depression can be a portion of that different parts of the brain are lighting up, having electrical activity, and that's why you're feeling crappy all around.
At what point you would consider MRI?
Mhm. First and foremost, most of the patients, I would say 95% of patients don't require any neuroimaging. If you have typical migraine, like if you've read the textbook and you follow the typical pattern, you started having headaches before the age of 30, they've ebbed and flowed, there's some hormonal basis, they run in your family, you have typical triggers, and this is a discussion you can have with your provider, and you have a normal neurologic exam, including an eye exam, we feel pretty reassured. You probably don't need to be exposed to any additional radiation, and we can absolve you of this responsibility of getting an MRI. But if you're concerned about it, and if you really feel that this would make you feel better, for example, to know that there's no structural abnormality, then this is a discussion we have with our patients that in general, it's not recommended unless there's a headache pattern change, or you have new symptoms, or there are other things like exertional headaches. If your headaches are worse with coughing, sneezing, bearing down, if they're positional in any way, like a lot worse if you lay down or a lot worse when you get up, if you're having vision abnormalities, all of these things should be discussed with your provider. And that might be a reason for you to have to pursue some additional neuroimaging at that time.
Positional headaches and headaches occurring during coughing or sneezing, they might be related to the high or low intracranial pressure, so CSF pressure in the brain. So that seriously needs to be investigated if that's the
Mhm.
case.
And if you do have a patient that came in with migraines, maybe they're slightly abnormal, it triggers you to get an MRI. Are you going to see anything at all?
Mhm. This is again a bit controversial. Generally,
Yeah.
most patients will have a normal MRI, but sometimes we see these white fluffy spots within the brain itself. And I tell patients those are small scars that have been left behind from migraine. Those same spots can also come from other conditions. So it's important that you get a comprehensive evaluation and an exam, and an understanding of your other medical conditions for us to understand exactly where those spots are coming from. Most of those are benign. They're never going to bother you in any kind of way. They're just souvenirs from a life with migraine. But in general, most of the patients, when they come and see us, I like to show them their MRIs so they can appreciate
Yeah.
how small and inconsequential those spots may be. But again, having those pictures is really valuable because sometimes it can also be an underlying cause of other things like autoimmune disease, like multiple sclerosis, or history of strokes, chronic ischemic changes, those are called. You can appreciate that having a look at the MRI, in addition to a comprehensive view of medical history, surgical history, family history, the other medications you're on. It's a really overwhelming, comprehensive view of the patient themselves.
Absolutely. It sounds like you need a 4-hour initial patient visit to get all the to get all this stuff done
I think I would
right.
get fired if I saw every patient for 4 hours, but I wish I could. I wish I could. But
I
it
know,
is
don't we
important. We
all?
have to, we have a responsibility to listen to the patients. And that's why
Yes.
patients are very well prepared. They bring the records with them and they bring their notes. It
Wonderful.
can be really very helpful for us to get to the answer quickly and to help them understand their treatment options. But I think headache medicine requires patience and understanding,
Yes.
just like most of neurology. So.
Absolutely. Well, it sounds like you have boatloads of it. So your patients are so lucky to have you. Amazing.
Yeah, and I'm glad you clarified those white spots in the brain, the white matter disease,
Mhm,
tiny little spots on T2 flare
mhm,
sequence.
yeah,
So many patients see this in the report and they do search on the Google and they're concerned about it. So for the listeners, these spots are very common, especially if you have a long-standing history of migraines. And most of the patients, they are just benign. So now jumping to the treatment, there are two main categories of treatment, the acute treatment or abortive treatment to abort the migraine attack that's already established. And there are preventative treatments that you take preventatively every day to prevent a migraine attack from coming on. Can you talk about these common forms of treatment?
mhm. Sure. We'll start with prevention treatment first, because I think more than 50% of patients who really deserve to be on preventative treatment are even offered preventive treatment. So we have a lot of work to do in that regard. In a sense, the American Headache Society has new guidelines that were published this year that really say that anyone between 2 and 4 migraine days per month should be at least offered a preventative therapeutic. And I tell patients that too, that if you're not being offered, you should be talking to your doctor, either primary care physician or your neurologist, about starting something preventative, especially if your migraines are unpredictable, you're missing school, missing work. We're swaying away from numbers, like how many numbers per days, per week, per month are you having in terms of migraine, but really how is it affecting the quality of your life? Are you missing school? Are you missing work? Are you missing family functions? At this stage, it's probably unacceptable for us to be doing that, and we deserve to offer our patients prevention therapeutics. For a long time, all we had was stolen fields of medicine. Those were antihypertensives or anti-blood
Mm.
pressure medicines, anti-seizure drugs, or antidepressants. And we learned about them because the patients that had those conditions also had migraine. And they told their doctors, hey, my seizures are well controlled. Hey, but I haven't had a migraine in a while. And the medical community decided to study it retroactively and said, okay, this may or may not work. But as you can appreciate, those medicines were designed for other reasons. So they carry a lot of side effects. Now we have migraine-specific prevention therapies, which include botulinum toxin or Botox, which is done in the office. And we have all the new CGRP drugs, some which are injectable, some which are IV, and some which are oral daily dose. So you can really appreciate the landscape of what you would like to get out of your migraine treatments is more vast than ever. So it could feel like a menu for our patients. They get to choose what category of therapeutics they'd like to pursue, but really the goal is that the burden of migraine is minimal in their life. When we talk about rescue therapies, what to take as needed, the goal is never to reach for anything more than 2 days per week. But if you're having to reach for things, we give you different medications for different migraines. We use other things like nonsteroidals, triptan medications, the new class of medicines like Gepants, even other off-label things like muscle relaxers, antiemetic drugs. So really, I try to understand what symptoms bother the patient the most and try to cater my therapy appropriately.
Now, for a lot of these new migraine medication, especially the ones that are working prophylactically or preventatively, what is their side effect profile like? So, if someone's going to be taking a new chronic medication, I'm sure it's a big deal for them to think about how will this affect me in my daily life. So, can you tell us a little bit about that?
Yeah, generally the preventative therapeutics are pretty well tolerated, but we say that unless you're the patient that's been affected. So
Right.
I think that can be
Right.
very tricky when we counsel our patients. The old school generic prevention drugs, which I think are stolen from other fields, they do come with some side effects, things like kidney stones and sedation. They can affect our mood. And some patients do feel a bit reluctant to be on those classes of medications. And that's where there was a large unmet need to have these new CGRP kind of drugs, which are designed for migraine and have very minimal side effect profile, probably across the board, minimal constipation, some site reactions if you're doing the injection, for example. But in general, they affect your life at a minimal degree, unlike the old school drugs. Unfortunately, we're a bit limited by insurance approvals, and we love to fight with
Yes.
insurance
Yes.
companies to get these drugs. The American Headache Society has new guidelines, which do say that CGRP drugs should be considered and used first-line therapeutics for our patients. So I think the landscape is changing, probably in our lifetime. Hopefully, more and more patients can be feeling better using the new CGRP drugs in addition to the old school generics.
If a patient has a severe migraine attack lasting for days,
Mhm.
At what point do you think they should be concerned about, say, for example, a brain bleed, or they should be coming to the emergency room for treatment or investigation?
Absolutely. I think this is a great question, especially for our patients who already have headache, because you can appreciate headache has been such a big part of their life already. But of course, if you have any new symptoms, your headache feels different than your normal headache, if the headache is lasting longer than you're used to, and it's not breaking with your general rescue therapies that you're used to, if you develop any new neurologic symptoms, weakness, numbness, tingling, if you're having worsening nausea, vomiting than you normally do, you feel that you're dehydrated, anything unusual out of your norm, I trust my patients. I think that if they feel something is wrong, they should pursue additional therapy. Either that's reaching out to your provider through your messaging systems or presenting to the ER. I think better safe than sorry.
Especially neurological symptoms that come with the headaches. And if they are not familiar with those symptoms, like if it's not part of their aura, then they should be coming to the emergency room.
Yeah.
So for someone suffering with chronic headaches, what might that feel like for them symptomatically?
Yeah. So I think even more than the head pain itself, which I can imagine is so bothersome, making it difficult to live your life, I think there are other subtle signs also that patients
Mhm.
have with chronic migraine or chronic headaches. That includes other things like brain fog, memory impairment, word finding difficulties. There's sometimes patients will say, like, Dr. Suneja, I've been working with you. I don't have that much headache, but I'm still not able to drive in the sun, for example. And I say, we
Mhm.
still have work to do. That means your brain is still sensitized even to minimal exertion from the sun, for example, or I can't go to a concert because loud noises will still trigger a migraine. And that again is a sign that the brain is still sensitized. So I think in general, chronic migraine and chronic headaches can present in other ways in impaired functioning, even despite the headache, which obviously is one of the most bothersome symptoms for most patients.
Mm.
And also in chronic headache, other things to emphasize are they are very commonly linked to other chronic medical conditions like
Mhm.
insomnia, hypertension, diabetes, mood disorders, and they have to be treated.
Absolutely. And it's like the
That
chicken
makes
or
sense.
the egg, right? Like in the sense, if you were in pain every day, of course, there would be some degree of depression, anxiety, and insomnia. So I always say it's
Yes.
important that we treat everyone as a team. When I can get your headaches better, but if you're still feeling depression or anxiety or insomnia, it's important to see psychiatry and your primary care doctor in addition to me to get yourself feeling better.
And when does just acute headaches? I mean, we all get headaches every once in a while. Maybe you have a too few many cups of coffee, you're a little short on sleep. But when do these sort of acute sporadic headaches turn into a true chronic headache? What's the timeline that's sort of required for that diagnosis?
Sure. So I think my top recommendation for your patients would be that they should keep track of their headaches. When they come in for an initial evaluation, these are the questions that we'll ask. How often is the headache bothering you? And in general, when we call something chronic, first and foremost, it have to be in the same pattern for at least 3 months. So if you have a headache here and there and it's happened for a week or two, you haven't really declared yourself. Your body hasn't shown
Sure.
us what pattern you're going to really develop, especially if you're in your 20s and 30s when migraine is first evolving and developing. So
Mhm.
when we look at the month in a forecasted kind of way, we split the month in half. And we say if you have less than 15 headache days per month, you have episodic migraine, migraine here and there. And if you have more than 15 headache days per month, we call that chronic migraine. That's a sign of headache days per month. Migraines are a little bit more nuanced. You have to have at least 8 of those to be migrainous. But again, probably less important for us to distinguish this as a patient, but it's a great idea to keep a headache diary, keep track of how often your headaches are bothersome, how much medication you're having to use, even if that's over the counter medication, because all of that will be discussed during your evaluation when you meet with your doctors.
At what point would you consider the headaches are from medication overuse?
Mhm. So
And what
when
medications?
Yeah, I think this can be tricky because we always reach for acetaminophen or ibuprofen, over-the-counter Excedrin. They're considered safe because they're available over the counter to most of our patients. You can imagine if you're suffering a lot and you're reaching for these medications, I tell patients, of course, it's going to be hard on your stomach, kidneys, and liver, but frankly, it's making your headaches worse. And we generally, as a rule of thumb, suggest no more than 2 days of treatment per week and roughly
Mhm.
10 days per month total. That mainly includes over-the-counter medications which patients have access to, but even prescribed medications such as triptan medications, you have to be a bit mindful. And the reason for this is a condition called medication overuse headache, which I tell patients Your brain is addicted to these over-the-counter medications and it's craving it the next day. And some of your headaches are going to come from that craving. Some of them are coming from migraine. And I don't know which is which, and neither do you. So it's a good idea to clear the system from these drugs. And it would be wonderful if you could do that even before you start the preventative drugs, because in general, all the therapeutics are designed for migraine management. They don't really treat medication overuse headache. So if there's some confounding variable, it's a good idea to get rid of those overuse medications so you have a clean slate, clean understanding of how much migraine is really affecting you so the medications can work even better.
Sure. I mean, it sounds like headache medicine is one of the most personalized types of medicine you can possibly get. There's just not 100% an algorithm that you can just throw at someone. It's like
Yeah.
you really have to get a great history and you have to look at that headache diary and dive down to see exactly what their headaches are coming from and then treat all possible causes before even treating the headache itself. So it sounds
Yep.
like you guys do a really thorough job over there at Cleveland
Yeah, and
Clinic.
that's the beauty of headache medicine. I
Yeah.
would say it's my dream job, and hopefully you can see that, but it's because it's
Yes,
personalized and it's a little bit artistic, right? It's like we're
absolutely.
little detectives. We try to figure out exactly what type of therapeutic option would be good for our patients, but the patients will lead you in that direction. They will tell you, I prefer an oral agent, or I prefer injectable, or I need something that acts really fast because my vomiting kicks in. And our job is to find the right medicine option for them. And of course, some of
Mm.
this is trying medications until we figure out a good therapeutic plan, layering the therapies and having regular follow-ups with them until they're feeling as best as they can.
Absolutely.
One of the special situations that headache medicine doctors like you face are headaches in females, especially menstrual headaches and headaches during pregnancy. Can you tell us what is your treatment approach for these two types of headaches?
Sure. So I think you make a wonderful point because in general, migraines affect young females disproportionately more than anyone else. And that is the most functional time of our life, right? We are getting married and having children and establishing ourselves in our careers. So you can appreciate this is the time where we really can't afford to have so much headache interfering. So I think aggressive intervention early on in terms of prevention with contraception planning on board is really important. So actually, whenever I meet with a patient in their childbearing age, I always try to discuss with them that, do you have any game plan for pregnancy in the near future? Are you on contraception now? And how can we ensure that we've selected an agent that would be safe with the game plan of watching out from that agent, for example, if you're planning to conceive in 2 years. We try to choose safe options during this conception period and pre-pregnancy planning. But of course, in general, I'm lucky because most headaches improve during pregnancy, especially after the first
Oh,
trimester. So most of my patients will come back to me once they've started lactating, for example. But of course, those patients that unfortunately continue to have headaches through pregnancy, we do offer them therapeutics, including nerve blocks and safe medications in pregnancy. And really, that's a discussion that we have very closely with them, the benefits and risks of treatment during that time. I think your last question was about menstrually related migraine. And that's a very predictable kind of migraine. And we can cater therapies that are called mini prevention around that therapeutic window where we know predictably that's a trigger or that's a reliable time that migraine is coming. So we can schedule therapeutics such as a triptan 1 or 2 days before the period begins, continue it throughout the period, and allow them other therapeutics if they need it during that time. So again, the goal is to keep these patients functional and living their lives. So.
absolutely. Is there any data on what the hormone is that is causing these premenstrual periods?
Yeah, usually we blame estrogen, but
We
the
love to blame
abrupt,
estrogen, don't
yeah,
we?
abrupt withdrawal of any of the hormones.
Yes.
We see this again in the perimenopausal period between the
Mm,
ages of 45 and 55. We call that a perimenopausal dip because migraines
mm,
go again haywire and really it becomes unpredictable. And many patients get very concerned because their headache pattern is changing and evolving. Many of them get repeat MRIs even because we're so concerned about them. But again,
mhm.
generally we say we should outgrow migraine without aura after menopause, for example. So I think the fluctuations of hormones is probably the biggest trigger for all of these unfortunate females that are affected with migraine in this way.
That's great to know. Thank you. We can move on to our favorite topic, which is
Okay. You see a
post-traumatic
lot of post-traumatic
headaches.
headache or?
Well, in your practice, do you see a lot of post-traumatic headaches, and what does that look like for you,
Yeah,
if
we
so?
do see a lot of post-traumatic headache. And again, I think post-traumatic headache is a big blanket statement. It
Yeah.
really doesn't help us understand anything about the brain itself. But as you can
Mhm.
appreciate, many of the patients get frustrated with post-traumatic headache because their
Mhm.
MRIs are normal, but they still don't feel well. And that's why post-traumatic headache can be so disabling. And sometimes the patients do have some prior injury. They had blood in the brain, for example, or some structural abnormality. But for many of the patients, I tell them, your brain looks good, and I understand that, but I can understand your suffering. It's like when our TV looks good and we have all the wires plugged in, but the TV isn't turning on, no matter how many times I restart. And I can understand how frustrating that may be because the TV looks fine, the wires look fine. But as you can appreciate, they're still disabled by many of their symptoms. And I think that is why it's really important that we listen to the patients as to what kind of symptoms they're having. And in general,
Mhm.
I'm sure in your clinical practice as well, you see post-concussive syndrome, and headache is a
Yes.
small portion of that, but they're affected by other things like brain fog and word finding difficulties, trouble sleeping, mood abnormalities. So really finding one good therapeutic option for them can be difficult. I think my
Yeah.
first step when I evaluate post-concussive care is again trying to understand what kind of headache they're having, and that's called phenotype. Understanding what
Mhm.
type of pain they're having, giving them a diagnosis, and again, a multidisciplinary approach is crucial for these patients. They really need good physical therapy, good occupational therapy, good psychotherapy, cognitive behavioral therapy, in addition to the medications, maintaining a good routine, and all the other lifestyle factors that we go into. But generally, most of them have mixed features, right? They have a little bit of migraine, a little bit of cervicogenic headache, a little bit of tension type headache. So they can be difficult to treat. But again, I think investing in some of these other modalities can be really important in getting our patients feeling better.
Absolutely. Yeah, that totally makes sense. I run into a lot how most of these post-concussive symptoms, if you start solving one will solve the other, but then the opposite can be
Exactly.
true. If you can't solve one, the other one won't be solved. Like if they can't sleep, their headaches really just are not going to go away. So you're right. Just taking the time to make things incredibly personalized. Sometimes it takes trying a couple of different, as you called them, gummy bears. I love that analogy to try to see exactly what works for them and what's going to help that cascade start. Maybe if they can get some headache relief, they can get some sleep, they'll feel better, their mood will be better, their social relationships better, they're getting outside, they're feeling stronger, etc.
Absolutely. And when the brain looks good, we feel really reassured. So I tell them,
Mhm.
you're going to get better. It's just a matter of time. The wonderful news is that structurally, brain looks good. So we got to allow the brain to heal itself and allow us to provide you with that support in terms of medications and the other modalities that we talked about to get you feeling better and get you to that result sooner.
Absolutely. Now, for a lot of our patients, they tend to need medications that are less expensive than some of these new modalities. So we rely on things like propranolol, amitriptyline, and topiramate. Do you have any other potentially affordable ideas for our
Mhm.
patients out there?
Yeah. I think, of course, the Holy Trinity, the three of them are such wonderful drugs. I love them too. But
Yeah.
even manipulating those a little bit, like for example, if your patient on Topamax tells you they're having brain fog, you could try
Mm.
zanisamide, its sister drug, for example. Or if
Mm.
propranolol is causing worsening depression and fatigue, you can switch into a different beta blocker like nadolol or atenolol, for example. Other TCAs, can be tried, nortriptyline, protriptyline, but even other tricyclic antidepressants. If that doesn't suit the patient, then SNRI class like Effexor, Cymbalta, and Pristiq can be tried. So even manipulating those, listening to the patients if they're having side effects, but they're getting good results, we have a lot of room to move around even within those classes. But we use a lot of things off label for migraine, of
Yes.
course. Things like Depakote. We also use Namenda or one of the memory pills. We use a lot of off-label things like cyproheptadine or periactin, lamotrigine being another agent. So you can appreciate some of these are on label, some of them are off label. But again, as you
Yes.
mentioned, trying to cater to the appropriate symptom is really important.
Absolutely. Yes. So many off label medication uses. I always tell my patients, hey, like if you Google propranolol, you're going to say, why did that neurology PA give me a heart medicine? But this
Yep,
is why. Always have to
exactly.
get the extra alert for that one for sure.
So
Mm,
I do want to reiterate that we expect and we want to empower patients to bring options to their providers and really speak up. There's no need to suffer. Really tell us how migraine is affecting your life and really allow your provider to provide you with options so you can feel better sooner, get back to work, back to life, back to doing what you have to do. And really, it's a wonderful time to be treating headache more so now than ever before. So,
Oh, that's wonderful. I love a good, hopeful message for our headache sufferers here. There is light at the end of the tunnel, and we can absolutely help. That's great. Well, thank you so much for coming on the podcast. It's been such a pleasure to have you and your knowledge here and to just experience your passion for this world, your patients. And we are just so lucky to have you. So thanks again for coming on.
thanks for having me. It was super fun.
All right. Well, for our listeners, thanks for listening, and we'll see you next time.